Welcome, everyone, and thank you for attending today's Healthcare IT News webinar, Insight-Driven Outcomes, a focus on risk, quality, and provider networks, sponsored by SCIO Health Analytics. My name is Bill Sawicki, Managing Editor of Healthcare IT News, and I will serve as moderator today. We look forward to your questions and comments, which you can submit at any time by accessing the question box on your screen. We will make every effort to answer your questions during the presentation's live Q&A. As provider organizations continue on their journey towards value-based outcomes and reimbursement, such as MACRA, they face many critical decisions that will impact their business and patient outcomes. The risk is too high to rely on assumptions and interpretations. Providers must be able to take insight-driven actions around key areas such as managing risk and improving quality and provider network operations, areas that can significantly impact cost and quality outcomes. During today's webinar, you'll learn how provider organizations are adopting an insights-driven culture that delivers improved value-based outcomes. Our speakers for today's webinar are Jonathan Nyloff, President of Nyloff Healthcare Strategies, and Rose Higgins, President North America at SCIO Health Analytics. I will now hand things off to Jonathan to begin the presentation.
Thank you, Bill, and good afternoon and morning, everyone. Here you see the agenda, and I'm going to start the presentation by talking about some of the key trends that we're observing in the healthcare environment today, especially with a focus on their impact on providers, and then use a little sort of crystal ball activity and try and see if we can make some predictions about what the healthcare environment might look like in the future. So starting with thinking about what's happening in the world of contracting, I think we're seeing that there's now a maturing trend in the movement away from fee-for-service care and more towards value-based care, where providers are increasingly at risk for both the cost and quality of the care that they're delivering to populations. We haven't yet reached a tipping point. It's estimated that about 25% of healthcare dollars today are in true value-based models, and projections suggest that the tipping point when this will become a dominant model may happen around the, plus or minus the year 2020, but that is clearly subject to change. We see a lot of different types of value-based models today, including population-based models, bundles, pay-for-performance. I think that most of these models will ultimately prove to be transitional models, and as the marketplace matures and the contracting environment matures, we're likely to see more and more models that are more based on some responsibility for the total cost of care rather than segmenting responsibility among different components of care. Certainly, if we look at the different types of programs offered by CMS and the incentives that they have in place, they have made that objective quite explicit. CMS started this trend again, if we think back on the previous managed care era back in the 80s and 90s, restarted this trend about 7 or 8 years ago. But clearly now Medicaid and the commercial payers are also transitioning their models to value-based care. The Sustainable Growth program was permanently repealed in 2015, and the replacement program MACRA legislation with its MIPS program and the mandatory bundles clearly demonstrate CMS's commitment to value-based care, and the incentives in the MIPS program with its zero-based budgeting, creating winners and losers, creates a strong financial incentive for providers taking care of Medicare patients to transition into a value-based model. This is causing changes in the delivery model We're changing from historically what I viewed as a transactional model of healthcare, where each encounter of the patient with the healthcare system was an independent event, disjointed from all their other events, to a population health model where we're seeing an effort at coordinating care across the continuum, and also provider network, understanding their populations and being more proactive about intervening in that population to drive better outcomes. We're seeing more and more narrow networks where patients are strongly encouraged with financial incentives to get all of their care within a given provider system, which of course is helpful when one's trying to coordinate care across the continuum. And we're seeing a change in what's considered the continuum, in the sense that much more care is being delivered in alternate care venues or via electronic modalities, including in the home. We're seeing much more retail health care. This started largely with urgent care centers or primary care being delivered in pharmacies and big box stores. But I think more and more now we're seeing that health systems themselves and even health plans are getting into the businesses of urgent care centers, freestanding urgent care centers, and even remote ER facilities in patients' communities and geographically separated from the parent health system. And finally, of course, we're seeing a lot of growth in telehealth, some associated with parent health systems and many completely independent. This can be both good and bad for care coordination, depending on whether or not that telehealth program is linked or not linked to the patient's primary care physician and is part of a care coordination program. We've seen the impact of the Affordable Care Act legislation that, including Medicaid extension, has resulted in over 20 million fewer uninsured individuals in the country. The effect on hospitals has been somewhat differentiated, in the sense that there's been much more benefit to hospitals in Medicaid expansion states than in non-expansion states. And as time has gone by, we've found that rural hospitals, including some critical access hospitals, are increasingly being challenged and are either being acquired or closing. The success of health plans on the exchanges has been mixed. In some states, payers have been very successful. In other states, and we're hearing this news all the time now, the success of health plans on the exchanges has been much more challenging, and we're seeing a lot of the plans now dropping out of their participation in the exchanges. We have a new administration, and as I think everyone knows, one of the campaign pledges was repeal and replace. I think we're seeing that the Republicans themselves are challenged to agree on a replacement program and understand that they will be held accountable. So I think the political reality is we'll likely see modifications as compared to a wholesale repeal and replace. But I find it more interesting from a provider perspective to think about the Affordable Care Act and the federal government's involvement in healthcare as really sort of two sides of a coin. One is the consumer insurance piece, which is things like mandatory participation, guaranteed coverages, the activity on the exchanges. And the other side is what the provider payment model will be, and specifically what is the fate of value-based care from CMS perspective. And I think that the net of it is that we're still going to need cost control. Cost of the healthcare costs in this country exceed that of any other country in the world. And whereas we may see, and maybe likely will see, some changes on the consumer insurance side of this, the continued promulgation of value-based models in terms of the provider payment segment, most people think will continue unabated. As a result of the transition to value-based care and some other market pressures, we're seeing consolidation among all segments in healthcare plans, providers, pharma. It's really across the board. And there are certain important drivers with respect to providers, and they're growing their networks, which they're doing both vertically and horizontally. One of the key drivers is to maintain market share, to the extent that in a value-based world, market share is determined by the number of PCPs one has affiliated with their network, because the number of PCPs really determines the number of patients that are getting their care within a given network, especially with narrow network plans. Growing your number of PCPs and your physicians becomes an important driver of success. The second is to achieve scale. Scale both for actuarial stability. So in a value-based contract, you are not subject to the fluctuations of a small number of sick patients on your overall performance. So having scale becomes important. It's also important for being able to support all of the programs that have to be put in place to support a value-based program, all of the analytics that Rose will talk about in a few minutes, all the care coordination programs and care management programs and everything else that goes along with it. And growth horizontally to obtain some level of coordination and control of care across the continuum. So much of the cost of care, especially in senior populations, happens in the post-acute phase, estimated that up to 40% or more of total costs of care in that population are in post-acute with respect to SNFs, long-term care, and so forth, that being able to coordinate care across all of the different facilities where a patient may go becomes very important in a total cost of care model. That said, there are limits. The FTC and state governments are limiting regional growth among providers. That has resulted in many networks now evolving their growth strategies to focus on joining or forming national networks to be able to continue to grow without running afoul of antitrust considerations. What's the impact on consumers? We're seeing a lot more consumer-driven plans where consumers are becoming increasingly responsible for a larger share of their healthcare costs. The data suggests that this is an effective strategy. We're also seeing, as I suggested earlier, more and more narrow networks where consumers no longer have as much choice in where they get their care, but are being encouraged and provided with financial incentives to keep all their care within a given network. It's interesting that if one thinks back many years, the concept of choice in Medicare couldn't even be debated, and now in the CMS Next Gen ACO program, there are financial incentives for patients who receive a large portion of their care within the ACO with which they're aligned. All of this has resulted in many consumers being underinsured and therefore challenged with high copays and deductibles. And the risk here, of course, is that some patients will not go for the care they need because of financial considerations, which can have a negative impact both first and foremost on their health and on their total cost of care, which is bad in a value-based world. So let's do a little crystal ball exercise and say, if we were to assume that all of the trends we're observing now were to continue to maturity unabated, and there isn't some sort of major event that happens in that process to derail current trends, what might the healthcare environment look like in a mature state? Well, I think first, as you think about the provider reimbursement model, value-based care would become the dominant payment model, with providers responsible for a large portion of the total cost of care, and most of the models will be total cost of care models or some proxies for total cost of care models. That creates essentially somewhat of a new paradigm of how we think about the economics of healthcare, in the sense that some of the downstream consequences of that are that the sort of major unit of analysis no longer become the hospital, but become the network, which is defined as not just the acute care hospital, but all of the other facilities that compose a fully integrated system, such as SNFs, rehabs, urgent care centers, and so forth, and all the physicians affiliated with all of those components of a healthcare system. The unit of payment that's important no longer becomes the DRG, but the focus becomes on the PMPM, the per member per month cost, both in terms as a revenue metric and as an expense metric across that large integrated system. Competition looks different. We see competition where hospitals, health systems are competing on quality and cost, and among those health systems that elect to form their own insurance programs, their ability to control costs actually gets reflected in their insurance premiums, which becomes part of the competitive piece of how they compete for market share by attracting members to their system. The success will in turn be based on a health system's ability to manage care, essentially perform population health, and to operate efficiently. So traditional operating metrics will still be important, but to be successful, one will have to be able to manage one's operating costs in the context of being able to manage a population and understand the complex interplay that happens between those two phenomena, because there are clearly trade-offs. Success specifically under value-based care will depend on the being able to enable and promulgate a really good new care model, and to be able to manage risk. Risk for the population and actuarial risk, and being able to sustain success in the face of those high-cost patients, which can be very problematic in the total cost of care model. Care delivery model. Care delivery will be delivered by teams with a focus on care coordination. We'll see much more care being delivered at alternative care sites. The goal will be to provide care in the lowest cost-effective and safe venue. And in a really mature model, one might imagine that a patient will only see a physician when they actually need a physical examination that can't be done remotely, or when a procedure is required. We'll see much less inpatient care and much more standardization of care. One could imagine IT systems that monitor care on a continuous basis. These systems are informed by real-time analytics on streaming data that leverages sophisticated analytics and predictive models that deliver real-time interventions and suggestions at the point of care. Delivery systems will be organized with providers tightly aligned to a single network. They'll extend across the continuum, and they'll include sort of tightly what we today consider alternative care sites, which I think will extend to include pharmacies and urgent care centers, with all delivered in a narrow network design. But we're on a journey. The tipping point is still in the future for most providers. The challenges today are conflicting contracting models. It's very difficult to operate when part of your patients are in fee-for-service and part of your patients are in a total value-based care model, and the incentives in terms of volume are diametrically opposed, and also challenging when different constituents within a network may have different tipping points, typically physicians reaching the tipping points earlier than facilities reach the tipping points. A lot of effort needs to go into the transition, and that is in the face of what are clearly today resource and capital constraints. So most provider systems today are focused on surviving the transition, building the infrastructure and programs and domain expertise to not only survive, but be successful in a value-based world. Often one of the early steps that are challenging is gaining access to good data for the analytics ones need, and achieving satisfactory physician engagement, and overcoming the challenges of workflow integration, data overload, alert fatigue, and all the other challenges of getting physicians to buy in. Well, as I said, we're on a journey, and I'm now going to turn it over to Rose to talk more about that and the analytics involved. Rose, take it away.
Thanks, Jonathan. So as Jonathan correctly described this, it really is a journey, and one of the things I think we all can fully acknowledge is that each organization is in a different place on that particular journey. But we really do believe that all begin with getting the quality house in order, and so certainly that is first and foremost as you prepare to take on any kind of population-based risk or other types of risk-based arrangements under these new value care paradigms, knowing really that you are delivering high-quality capability in terms of the service delivery is really important. And then certainly also the ability to document that and to provide that vantage point to any of the key stakeholders so that you can manage the organization effectively, but also compete effectively in the market for different business that you're seeking. Pay for performance, also something that's been on the landscape and part of most organizations' journeys for some time, and this is really cutting your teeth in preparation for that true assumption of the financial risk equation. And as we move up this journey path to that notion of assuming that financial as well as clinical and quality risk, this is really the stepping off point for organizations in terms of getting to that tipping point that Jonathan alluded to earlier. So the government has a point of view on how quickly we should be traversing this pathway. Certainly commercial payers have a similar point of view of moving more quickly down this risk-based arrangement. In order to do that effectively, one of the key tools and levers that will be available to organizations is really the notion of a network. That network, not only in terms of is it properly configured to deliver the kinds of capabilities and services required to manage population risk, but is it also optimized in a way that allows you to take advantage of a highly performing network and one in which you can continue to refine over time so you can really assure some success in terms of both those margins for services that are being delivered, as well as identify opportunities where you may want to partner or effectively acquire or build other capabilities to strengthen your position in the market, but ultimately judged again on the same parameters of delivering that highest quality care at the lowest possible cost, making sure that, again, you are efficient and performant in so doing. So how do one get started? And this is something that as we spend time with customers out in the marketplace, one of the areas that's really important for us is first of all, understanding the complexion of the organization, certainly. So are we talking about a provider-led physician group practice, IPAs, different types of structures such as that who are taking on this particular set of activities, or is it a health system that owns or is affiliated in terms of their physician practices, or as Jonathan mentioned, increasingly those organizations that have become insurance carriers and providers themselves. And certainly all of these things are not exclusive of payers themselves who are also looking at different ways in which they can partner effectively with providers or become, in some instances, providers themselves of care. But all that said, one of the key things to really understand is what data do you have? So in order to take this particular journey, you must have data, and you must have the data that you require to actually allow you to be effective at various stages of your particular journey. So as we think about analytics required to stay informed about what's going on, your basic operating blocking and tackling kind of information really comes down to understanding the risk that you have and that in the revenue profile of your organization. So are you being paid accurately? Are you actually being paid for those services that you deliver and have contracted for? And are you also doing that in a way that is efficient and effective? So starting there to really begin to understand how is payment in the context of your contract actually doing. Moving up a bit, you want to begin to add in data that's coming from that clinical record. Those transactions of care are very important, not only in terms of indicating what's being done, but who's doing it, are they doing it effectively, and at what cost. And one other parameter that Jonathan mentioned, which is really so key, is where is that care being delivered? So having that information then is going to help you understand where are those care gaps, where are those opportunities to improve the overall delivery of care, and at the same time understanding how are your providers doing in delivering that care? What's the profile of that quality? As we continue down this path and looking at what the network needs to be doing, you really are now moving into an arena where you simply must have paid claim data in order to be able to get a fulsome view of what's occurring. And that is really the first place that you can begin to look at network integrity, the way in which various types of practice behaviors and patterns may be emerging in terms of where care is being delivered. So knowing for really referral pattern as well as utilization. These are all the kinds of areas that are really critical to understanding not only is the network properly configured, but how is it performing. So these require different data along the way. Knowing the kind of data that you have available to you helps inform what you're going to be able to successfully do with that data, and obviously creating an insight-driven culture as you proceed. So building a framework to really get to outcomes is really one of the key steps along this way. And so again, as we talked a bit about, knowing what kind of data you have available is critical. What are the originating systems? But having a way in which you can efficiently transform that data and then apply analytical models to that data to really begin to predict what needs to be occurring. What has happened retrospectively, certainly important, but also beginning to predict and take a future view, if you will, of what you need to be doing in order to assure that you're going to be successful under these different kinds of value-based needs. And so each and every one of these has somewhat nuanced information that is applied to it. But when you look at the composite of being able to look at your revenue and whether or not that's been properly optimized, is it accurate, is it optimized, looking at your quality to understand if you're really capturing all of the critical metrics and making sure you're closing out any of those areas where gaps may exist, looking at that population, the totality of the populations of lives and types of conditions within that population that you have signed up to deliver care for, and then again, this really important lever of network and how are you doing in terms of delivering care within that network to all of these various constituents. So one of the areas that we find really fascinating is this expansion of the demand and need for new kind of analytics. So if you start on the bottom left, I think everyone would agree that as providers in particular, knowing the data that's relevant to that patient is the starting point. You've got to be able to look at not only the care and delivery that you have within your electronic health record, but beginning to add to that other kinds of data that may be in addition to that, and then using that information to help you create a profile. Each of these areas expands that profile, of, if you will, of that population. So population risk is one of the key drivers in terms of understanding what your cost, your utilization, and your demand might be. And so having the ability to look at that and then target those particular individuals and the providers serving those individuals is going to be an important part of that journey. In addition to that, site of service has really become one of the critical parameters, knowing whether care is being appropriately delivered at the right site of service, and also how much control in terms of the cost profile and the quality profile of that particular site of service do you have as that owner of total cost of care. And so having that information, which includes different kinds of eligibility data as well as zip code data, is really important really to understand the profile of the health care that's being delivered and where it's being delivered and whether or not that is good value for money. When we add to that new data sets, and this is the place where I think a lot of organizations who have been moving and progressing through this journey towards value-based care have now begun to understand that there's other data out there that would be useful to really inform what kind of people are in that population and how will they engage with you effectively as the providers of that care. what are their preferences, what are their patterns. And similarly, understanding, again, more detail about the physicians in your network and how they actually interact with one another in terms of accessing and utilizing services and care. All of this information is available, but you need to bring it into the context of these other cost and quality parameters, really to get a better sense of what are those different kinds of levers or drivers of behavior that you can begin to consider as you're doing program design and other kinds of work in this area. So if you're an executive and you're managing this kind of a value-based arrangement, getting a snapshot view of what your population looks like and having a better understanding of that is important. But it's also important to be able to do a comparison. So how did I look at this a year on year or month on month? This particular vantage point is a year over year. So what direction is this going? Am I actually seeing increase in the number of lives that I'm serving, or is it decreasing? Am I seeing the risk profile of that population increasing or decreasing? Is it in terms of gender and geography? What does it look like? What are the relationships between those? That's really information that's critical for you in terms of program design, as well as understanding investment as you think about the resources required for some of these changing parameters over time. And so if we look a little further, then we obviously want to understand what the cost profile is that goes along with that. And so looking at that total cost of care metric and then breaking that into the cost buckets, which are going to be ever so important as you do take on this new PNPM responsibility. So as you're thinking about what are those costs for each of those patients per month, you really have to have a sense of where that money is being spent. This will help you not only redirect and coordinate care, but also make some decisions in terms of whether or not you have the proper programs and partnerships in place to really take advantage of and improve your total cost of care profile. And that really is a combination of the cost buckets, but also looking at some of those in a very specific way. And what do I mean by that? So if I look at the utilization units at the bottom of this graphic, really by far and away, the RX drugs is one of the areas where I really need to understand what's happening in terms of medication management, what's being prescribed, how are those being prescribed and utilized by my patients. And so certainly there is a consideration around adherence and compliance that's going to be critical. But at the bottom, at the end of the day, if you will, the total cost of care ownership requires us to be more engaged around how that spend is occurring. So if we think about that in terms of, again, looking at the conditions themselves, it really helps us then understand in terms of centers of excellence or service lines that we want to emphasize or we want to reinforce or add additional value to. We want to be able to look at that both from the risk percentage but also from the total cost of care and how that care is actually being delivered and at what price point. So if I look at this, for example, I would have a quick call out that in terms of the highest risk population, it's really those with diabetes, but my total cost of care for diabetes is actually lower than other areas. And so thinking about where do I want to spend my time and my resource, these are ways in which you can begin to get to that decisioning. If we think then about the network and how am I going to deliver care in that network, now I have a point of view that's really informed by the population type. I've got a point of view now about the cost buckets that are driving that. And I also now have a point of view about if care is leaking from my network. And this is obviously very important. If you own the total cost of care, not having your hands around that kind of lever, if you will, to be able to bring that into control is really going to be a situation that can get out of hand very quickly. So first and foremost, knowing where that leakage is and what is that really that exposure, if you will, to your network and to your risk-based contracts, that's going to be important. But as we look at this, we only have a point of view that's really at a high level. I want to really get under the covers a little bit more and look more directly at what are some of the details behind this. So knowing that I have out-of-network care, which is trending, I think, frankly, in a very wrong direction for us. We've got a very significant percentage of our care is not being delivered within our network, so 42% odd here. So if we take a look at that, I want to know who are the providers that are caring for those patients that are not being served within our network. And so finding out, first of all, with what frequency that's occurring by provider, then also what is the cost impact of that. So that detailed information on leakage is really critical to helping you begin to outreach to those particular providers, understand who is in their panel of patients and membership that you may want to go out and work with directly, making sure that you're communicating what the impact of this leakage is to those providers. Really very important in terms of you being able to optimize that network and also create the loyalty and retention of the patients and membership, also going to be something very important to you longer term. And this is really a similar situation as we think about risk. So the profile of a patient population and the risk associated with that, we want to know what direction it's going in. And so as you can see here, if the trend across these three sort of classic buckets of low, medium, and high risk are all trending north, then this tells me something about the demographics of that population and the expected demand and utilization and needs of that population. And so I really need to get ahead of that. So from a planning perspective, there's obvious day-to-day management issues, but we really need to be thinking about this from a planning perspective. Where is this population taking me, and how can I prepare for that? And obviously contract most effectively to protect the organization as well as deliver that high quality and cost-efficient care. So taking a look at that, we want to also understand a little bit more about that risk and the profile of that risk. So we know that it's increasing, but if we look a little further, this notion of impactability, going that one step further, that each of these buckets that are the low, the mild or mid and medium and high risk buckets, within each of those, there are still segments of those populations which are moving from low, mild, medium, up to high within each of those particular buckets. So it gives me some focus, some additional areas where I can really get into the detail and understand which patients are moving up, if you will, who are the movers, which providers are caring for those patients, what are the conditions that I'm seeing in that profile. That helps me take those very finite and very precious resources and apply them in the right place. And if I put that in the concept of where is the geography in which they are being delivered, I also then can think about how do I conform my organization and my relationships to make sure that I can properly care for where that risk is actually seeking services. So it's really putting that notion of that trend over time in the context of the population parameters, using analytics to give me more detail around how can I focus my attention where I'm going to actually get good return on my investment as well as value for my patients. But at the same time, do I have the proper footprint in order to deliver that? So knowing all of those things really helps one plan appropriately and operate more effectively. And so certainly as we think about quality, we want a network view of that as well. So quality is not just the report cards that we are responding to or generating. It's also being able to look at that in terms of how is the profile of the provider care that is being delivered, which at the end of the day, frankly, is the product that all of the provider organizations are bringing to market. It's really important to be able to understand that in the context of the quality itself, but also in comparison to others within the network and then ultimately outside of the network, which is, of course, the purpose of those report cards. So I want to be able to look at the types of quality and the overall performance of quality within my particular conditions. And so this is a snapshot of how I'm doing. And so if I look at CHF, for example, and I'm looking at that in comparison to a benchmark. We think benchmarks are very important to give you that additional vantage point for which to measure and to course correct or adjust. You know, I'm a little bit lower than the benchmark, but generally within the ballpark, if you will. But if I move down and I look at asthma, I'm not doing quite as well there against the benchmark. So really wanting to make sure I understand what my compliance rates are in these important comparisons. So it's important to look at our own organization, but it's also important to be able to utilize benchmarks that are available for the industry that help us then to, again, course correct and correlate how we're doing in comparison to others with like parameters like populations and such. And so with that, we want to just make sure that we're always thinking again about the details that underlie that. So now I know how I'm doing. I've seen an aggregate view of that. I've seen a benchmark view of that, but I still have to get back to the tactics of how do I do this. And so I now can delve further and take a look at each of the provider groups, and I have a sense of what's occurring in terms of the overall scores. And so I can take this back to an actionable discussion, and I can take this back to a set of outreaches and engagements that are going to actually deliver back what we're looking for, which is, of course, an improvement in that overall quality of performance. And at the end of the day, data-driven discussion is the most critical. You can't simply come in and have an observational discussion. You've got to be able to come in with data. And so having this to show and to share really does help in terms of not only getting people to understand what needs to be done differently, but as you think more about the notion of your network and how that network is performing, really making sure you can state your case in the market that your quality is the highest and at great value, and having the opportunity to do that, again, from a set of very data-driven insights is going to be very useful in that conversation. And as we think a bit more about how do I bring this all together, at the end of the day, what we're really looking for is a composite view of how the network is doing. So if you think about how we started this conversation, we said it's a journey. It starts with quality. We build on that to really begin to examine our performance and receive payment for the quality of that performance, assuming risk, allowing us to actually then become very comfortable in the knowledge that we can deliver good quality care for these types of conditions and to these types of patient populations at this level of profile with this expectation of appropriate reimbursement. And then having that all come together at a network level. And that network then becomes really the primary driver for you in terms of being successful longer term under these different kinds of value-based arrangements, whether those are government-based arrangements or commercial arrangements. So you have a story to tell that's driven strictly through the use of data and analytics that tell you more about the overall outcomes you've been able to achieve, and to have that information at the ready to not only manage your operations and affect change within your network parameters, but to inform the dialogue you may be having in terms of contracting for other kinds of value-based arrangements, or thinking about how you, as Jonathan mentioned earlier, can think about plan design and benefit design and premium cost as it relates to those that have taken on insurance carrier functions and business as well. So all of these things together really are what the journey is actually intended to help you with, and to help you arrive at a place where you do have a performant network and you are assured that you have line of sight to the areas and the levers that you have at your disposal to assure that that network is performing and therefore successful under these new kinds of value-based arrangements. So really, in summary, at any given moment, we have two options. We can step forward into growth, or we can step back into safety. But as Jonathan and I were chatting a little bit in preparation for this, we both somewhat agree that stepping back into safety may not really be an option any longer, because the market is moving, the dynamics are there that have suggested that we're being propelled forward, and so we may be confusing the familiar with safety. And so certainly not to take issue with Maslow, but to point out that you've got to actually make some very informed, intentional decisions here, and really moving forward down this path is the journey that all of us are committed to. And with that, I'd like to turn it back over to Bill for any questions that you may like to entertain. Thank you.
Fantastic. Thank you so much to our speakers for that very informative presentation. We do indeed have time for a few questions, so let's begin. First of all, first question from the audience: how important is the role of workforce training and organizational culture in enabling value-based care?
Well, that's a great question. Jonathan, you want to start?
Sure. Thanks, Rose. So, I think it's actually a critical question and a really important question, because at the end of the day, if the organization isn't on board with a population health approach and doesn't understand the business and operational and clinical imperatives of performing in a value-based environment, the organization will not be successful. And I think it's especially critical that the physicians be on board, because ultimately they are controlling a lot of the cost. And, you know, if you think about it, the challenge is helping the physicians transition through these sort of conflicting incentive worlds. So I think, first of all, a lot of the physicians who have been around from the previous era of managed care back in the 80s and 90s, you know, have a bad taste from that, if you will. So I think the first priority is they need to be educated about the new value-based care and how that differs from the old era of managed care. And they need to see a very clear path for their individual and collective success under the new model. I think they need to be given a very consistent message. If they're being told by the managed care or the value-based care part of the organization to perform in one way, and the hospital CFO is telling them to perform in a different way, that becomes a big challenge. So you clearly need organizational alignment. And I think it's also really important that the internal incentive structure and compensation incentive structures are aligned with the value-based model and not with the old fee-for-service model, when the rewards are all for volume and doing more cases or seeing more patients, as the case may be. Often very difficult to achieve in academic arenas especially. And finally, I think it's important that to drive that cultural change and that behavior change, that you'll make it easy for all of the clinicians to be able to practice in the new model, which means the right support systems, the right information systems and technology, but to make sure that that technology doesn't create extra work or what's perceived as extra work for your workforce, but it's well integrated into the workflow, where appropriate integrated in the EHR. So what I often say is make it easy for everybody to do the right thing.
Okay, another audience question. What initiatives are trending to assist networks to effectively perform comparative analytics with other networks?
So I would say that the primary driver here is really the use of benchmarks. So one of the things that is very readily undertaken is the acquisition of benchmarks to be able to allow you to get a better handle on how you're doing, but also in comparison to others. And so while networks themselves may not necessarily be prepared to share that information, there are good tools and assets out there that allow you to get those insights and to give you some sense as you think about your strategic plan and your operating model going forward, how you're doing in comparison to others. But you may find that there are good partnerships, alliances to be had as well. So as you determine whether or not you have the right network in place and you are comparing to a benchmark and you see opportunity, perhaps the most efficient way to take advantage of that is not necessarily to go it on your own and build that capacity or acquire that capacity, but perhaps partnership models and alliance models. So benchmark data, I think, is in some ways underutilized, and certainly I think something that can really be very helpful in trying to create information that may not be readily shared amongst organizations that may be competing today, but certainly could also be cooperating and partnering in the future.
Very good. Another question. What impact has the ACA had on the value-based model, and what impact would repeal of the ACA have on the model?
Okay, well, that's a bit of a crystal ball in terms of the future. But I think that in terms of the impact it has had, it has been to advance the value-based care models by CMS. Some of that has been directly attributable to the ACA. Some of that has been attributable to the macro legislation with the MIPS program, which is separate and independent from the ACA. But I think the net-net has been to drive more value-based care. There were several other provisions of the ACA that impact the industry. The special funds that supported hospitals that care for a high proportion of low-income citizens was abolished, and that has created pressures. The increased number of Medicaid beneficiaries in the states that expanded Medicaid has provided for more, if you will, paying customers, which mitigates the loss of the special funds. So there's been many different dynamics. Similarly, the citizens who purchased insurance on the exchanges has increased the number of, again, if you will, paying customers, but because of the high deductibles and copays and so forth, that has increased levels of bad debt. So there are many benefits and many challenges that have been associated and impacted providers as a result of the ACA. What will the future bring? I think if we see less funding for Medicaid, we'll see less enrollees in Medicaid, which will potentially cause less revenue for hospitals and physicians. The fate of the exchanges is challenging. With mandatory participation goes away, then the exchanges may become even less stable, causing less insured patients with potential revenue impacts from that. I think, though, with respect to value-based care, if the states have decreased funding for Medicaid, that will make the need for them to control their expenses on the Medicaid beneficiaries that much more, and may actually drive and accelerate the pace towards more advanced models of value-based care in the state Medicaid programs.
Very good. Our next question from the audience. What is the industry seeing as an impact to providers as a result of the increased prominence of narrow networks? How is this impacting their business?
So, Jonathan, I'll take a quick pass and certainly add on. I think one of the things, first and foremost, is whether you are a participant in that network is critical. And so making sure that your performance has been there to demonstrate that you can be effective and efficient and therefore should be in that network is very much top of mind for many organizations. But being in that network also means that you have to have continued success in delivering care to those populations that are seeking care within the network. And so constantly refining and improving your margins by making sure that you are focused on doing the right care at the right place at the right time, very important. Continuing to look at the providers within that particular network to make sure that they are certainly getting the job done, both from a cost and quality perspective, and looking to make sure that if you find there are any aberrations or variations, that you're dealing with those quickly and effectively. But making sure, first and foremost, that you're part of the network, understanding what, as I think Jonathan mentioned, is a very important part of this, is we have to remember what the consumer's responsibility is as they seek services. So while you want to be in that network, there may also be some risk and exposure to you in terms of bad debt or prompt pay, or your ability to make sure that those folks that are being cared for are, again, doing so in a way that you're not losing money in the process, but at the same time you are making sure that the good quality care is being delivered when they are seeking services within that network. Jonathan, anything you'd add?
Sure, just a couple points I'd make. Thanks, Rose. I think one is that one of the impacts is that certainly narrow networks help health systems be successful in care coordination, in the sense that the patients will be subject and part of their care coordination programs that extend across the continuum within a well-developed, mature narrow network. I think the other thing to think about with respect to narrow networks is there will be winners and losers. And in fact, it's not even a zero-sum game to the extent that from a hospital perspective, there will be fewer and fewer inpatient admissions over time. It's actually a negative-sum game. So those that are successful in attracting patients to their networks from a hospital perspective will fare much better than those who are less successful. I think it also becomes increasingly important as you think about in a health system that has acute care facilities with fixed numbers of beds, amortizing the costs of bricks and mortar over time, that if they can win in the narrow network competition with other facilities in their medical service area, that's an important mitigation strategy to fill some of those beds. So, if you have, the bigger population you have, even if the rate of admissions falls, a bigger population will mitigate for some of those what would otherwise be empty beds. So the narrow network becomes potentially very important in some of your long-term cost commitments from a facility perspective.
Okay, thanks to those of you who submitted questions. Unfortunately, we are out of time today. We'll address all your questions after the webinar. Please be sure to complete the evaluation and share your thoughts with us. I'd like to thank our speakers for taking the time to share their expertise with us today. And today's session will be available on demand until September 7th. Thank you all, and have a wonderful day.